Hello, my name is Professor Neil Poulter. I'm Chair of Preventive Cardiovascular Medicine at Imperial College London, and I'm currently the President of the International Society of Hypertension. However, the views that I'm about to give you over the next 30 minutes or so are those of my own rather than necessarily those of the International Society. And over this next half an hour or so, I'm going to talk about managing hypertension with comorbidities. And as a background, this first slide shows the story about how common dyslipidemia and diabetes are amongst patients with hypertension. You can see there that of people with hypertension, about 2/3 have got dyslipidemia, depending on how you define it, and about 1 in 6 have got type 2 diabetes. And given that 45% are overweight and obese, that probably means that over half of these patients have got either pre-diabetes or diabetes itself. So, if we look at the causes of death, list risk factors for causes of death reasonably recently, I realize this looks a long time ago, but actually updated data not yet published is pretty much the same. You'll see that high blood pressure is the biggest single contributor to death. About 10 million people a year die of high blood pressure as a result of raised blood pressure. And then if we look at high blood glucose and physical inactivity, you'll appreciate that's really what diabetes is all about. And then we add high cholesterol. Just those three problems, diabetes, high cholesterol and high blood pressures, are huge contributors. 4 out of the top 6 causes of death around the world. So they coexist a lot and they're big killers. So it's very important that we consider them when we're managing high blood pressure. So back to the title of my talk, which comorbidities do we have time to talk about? Well, there are lots that we could talk about within 20 minutes or so, but I'm going to focus on the ones shown here: dyslipidemia, diabetes, established cardiovascular disease or those at high risk, isolated systolic hypertension, which you'll appreciate is linked with old age, so the very elderly. Then left ventricular hypertrophy, a little bit on heart failure, and finally a word on ethnicity, because cardiovascular disease differs greatly amongst ethnic subgroups. So first of all, dyslipidemia. Well, we go back almost 15 years now to the European guidelines, followed by British guidelines, and they said essentially this same thing, and that was that in view of the results of the ASCOT trials and other currently available data, this is 15 years ago, it seems reasonable that in the interest of simplicity we should treat with a statin all patients, at least up to the age of 80, with a total cholesterol of greater than or equal to 3.5 millimoles per litre. If you want that in milligrams, multiply by 40, so you're talking about 135 milligrams percent, who have an estimated 10-year cardiovascular risk of 20% or more. In reality, this would mean considering statin therapy for most hypertensive patients, especially men over the age of 50 years, and of course most hypertension is over the age of 50 years. And they also said prophetically, as resources allow, a rationale for lowering this threshold could be made on the basis of trial evidence. In other words, adding in a statin is pretty much a no-brainer when you're managing hypertension. You should be thinking, why would I not give this patient a statin rather than why should I? So that's lipids and dyslipidemia. What about patients with type 2 diabetes? Well, this slightly complicated slide tells you the effect of lowering blood pressure by 10 millimeters systolic. Based on 40 trials, 100,000 patients, and on the left-hand column it shows you all the things that you may or may not care about, going from the most important, mortality, down to albuminuria, which some people get very excited about. But whatever of these endpoints you care about, and we all do to one extent or another, you see here that this 10 millimeter reduction in systolic blood pressure is associated with big benefits in patients with type 2 diabetes. So it's an important thing to do. We should be lowering the blood pressure in patients with type 2 diabetes. The question is, what with? Well, going back nearly 14 years now, British Hypertension Society guidelines, this was a good review of the data at the time. All patients, almost all patients with hypertension and diabetes will need a combination of blood pressure lowering drugs, certainly if we're going to get to current targets, which is less than 130 systolic. And the evidence for renin-angiotensin system blockade, especially for nephroprotection, if that matters to you, and the reduction in surrogates such as proteinuria, which once again many people get very excited about, but most importantly about CV protection, strongly support the use of an ACE inhibitor or an ARB as part of the treatment cocktail, especially in those patients at higher cardiovascular risk. By virtue of established target organ damage. So RAS blockade was recommended then for everybody, at least in a combination, and just about all diabetics need a combination. So now if you go back to British guidelines 2011, this were the NICE guidelines. On the left hand side you see those under the age of 55 were recommended to an A drug. That's an ACE or an ARB. If you're 55 and above or black of African or African Caribbean origin, you're recommended to a C drug. Now at this time, if that wasn't enough, they said, well, put those together, A plus C, standard combination, we'll come back to that. But many felt at this time, and diabetologists, many of them say that diabetics should be treated as if they were under 55 from this treatment allocation point of view, i.e. start with a RAS blocker. I don't think the evidence is very good for that. I actually think that if you're older, diabetic or not, you start with a calcium channel blocker. We've heard in the previous slide that you're going to need a combination anyway, so A plus C. But your main aim is to lower the blood pressure, and the drugs that will do that best, diabetic or not, if you're above 55, is a calcium channel blocker, and I mean dihydropyridine. So that was my personal belief, but many diabetic guidelines will suggest that you should start with a RAS blocker. I don't think that evidence is good. So, what should we use in the trials? What's the base of the evidence in the trials? Well, here you see the results of the ACCOMPLISH trial. This is where patients, and about 2/3 of these were diabetic. They got a calcium channel blocker, amlodipine, or the ACE inhibitor benazepril, which isn't used in UK, versus benazepril plus low-dose thiazide. And the primary endpoint, classic composite of cardiovascular death and cardiovascular events, highly significantly reduced in favour of the calcium channel blocker ACE. A plus C, as you'd say in the British NICE type setup. A plus C turned out to be better than A plus D, where D was a thiazide diuretic, low-dose thiazide. So that's really what drove one of the bits of evidence, along with the ASCOT trial, that made A plus C the recommendation for NICE as their best combination. But in terms of diabetes, I think this is one of the best bits of evidence, albeit the majority of the patients who took part in this trial. The other trial, which was specifically set up to look at patients with type 2 diabetes, this is the ADVANCE trial, whether you are hypertensive or not, you're randomized to placebo or the ACE thiazide-like diuretic indapamide. And here you see this in this trial, the perindopril indapamide gave a significant 9% reduction on major macro or microvascular events in the trial associated with the use of the ACE inhibitor or thiazide-like diuretics. So in diabetes, we've got ACE inhibitor plus thiazide-like diabetes, or the ACE plus CCB we saw with ACCOMPLISH. What about the targets in diabetes? Well, this is a summary of the guidelines up until very recently that we all ran along with. And basically just the middle column shows what targets was recommended for the diabetic patients. And that's really what everybody said, 130/80. But then along came the ACCORD trial, which showed really no significant benefits of getting lower rather than higher, 120 versus 140. So everybody, or several trials, went back to the 140/90 or 140/85. The rest of the world had previously been very happy with 130/80, but because of ACCORD, rightly or wrongly, instead of sticking with 130/80, they jumped back to 140. I think that was a mistake. And indeed, subsequent to those guidelines, the Canadian guidelines of 2014, and now the enormous American guidelines with lots of co-authors, I've only shown ACC and AHA 2017, they've gone back to 130/80. And I have to say, I think that's right, at least for diabetic patients, less convinced about the uncomplicated setting. So now if we turn to coronary artery disease, shown here, and stroke, shown there, based on the trial evidence in 2013, ACC, AHA, CDC, in their recommendations for blood pressure lowering with different settings, they came out here post-MI with beta blockers and ACE inhibitors for coronary disease, and for stroke, thiazides and ACE inhibitors. They don't mean thiazides because the evidence was actually with thiazide-like. The evidence here was with indapamide, and that's thiazide-like, but lots of the guidelines get confused about how to describe the different drugs, and thiazide and thiazide-like get messed about. It should really strictly read thiazide-like in that setting. Here you see the evidence post-stroke. These are patients who got randomized to receive perindopril, adding in indapamide as required. That's the active treatment against placebo. And here you see the benefits. This is the placebo lot. This is those who got the active therapy. And you see this highly statistically significant reduction in second stroke. So that's really why the guidelines have stuck with ACE plus what should be thiazide-like diuretics. Now, what about post-MI? Well, this is the standard post-trial. It really should be a polypill by now, shouldn't it? A beta blocker, what's your favorite? An ACE inhibitor, what's your favorite? Statin, and then antiplatelet. Dual therapy, usually for antiplatelet. This is a standard recipe for people post-MI, but notably always includes beta blocker and ACE inhibitor. Beta blocker, the evidence really goes out for a year, maybe a bit longer. Beyond that, I think it's less compelling. Then it may be that after a year or two we should be using other agents, but that's not proven, in inverted commas, at least by a randomized trial. The story about beta blockers is an important one, and this is the sort of thing I think lots of countries use beta blockers in settings other than post-MI, and I think that's unwise. I think this is one example. We've known for over 10 years now that the available evidence doesn't support the use of beta blockers as first-line drugs in the treatment of hypertension unless you've got established coronary disease or maybe heart failure. And that conclusion is based on the weak effect of beta blockers to reduce stroke and the absence of an effect on coronary heart disease when compared to placebo or no treatment in primary prevention, which is most of our hypertensive patients. More importantly, it's based on a trend towards worse outcomes in comparison with all the other drug classes. And here's the Cochrane library once again using the term thiazide. They didn't mean that, they meant thiazide and or thiazide-like. But nevertheless, the message was true over 10 years ago that beta blockers do not have the support of use except when you've got concomitant conditions like heart failure and coronary artery disease. So, what about which to use, ACE or ARB? Big ongoing controversy, and the only trial that's pitted them one against the other was the On-Target trial. This was telmisartan, a long-acting ARB, against ramipril, which is a relatively short-acting ACE inhibitor. And then you have the combination of the two. Importantly, the combination of the two was no better than either of the single drugs. Despite better blood pressure lowering, what it did cause was adverse renal events. We should not use this combination of ACE plus ARB. It's one of the key messages to come out of this trial. Telmisartan versus ramipril, or long-acting ARB versus short-acting ACE, they were about the same. You may have your own beliefs, and I have mine about which is the better drug to use. But certainly the ARBs have fewer side effects in terms of cough. But mortality evidence, I think, is perhaps going in the opposite direction. Anyway, these are the evidence basis of which the only head-to-head between ACEs and ARBs made some believe that we should treat them or give either equal support. Let's now go back to the elderly in the very isolated systolic. This was the systolic hypertension, the elderly program, the SHEP trial, and this was using chlorphalidone against placebo. And look at these huge, lovely hazard ratios showing the protection of patients who got isolated systolic associated with this thiazide-like diuretic. It is not a thiazide, chlorphalidone. Great benefits shown with the use of chlorphalidone in the situation of isolated systolic. Here's another one in isolated systolic. This was with the calcium channel blocker down there at the bottom, nitrendapine, not one many of us use, I don't think, but nevertheless, dihydropyridine against placebo, and here you see these big reductions, stroke, all cardiac and all cardiovascular, big benefits, supporting in this setting of isolated systolic and therefore the elderly, the use of dihydropyridine calcium channel blockers. And then we got the very elderly. These were 80 plus patients, and they got randomized to indapamide, adding in perindopril as required. And what you see here for all stroke, very elderly, stroke death, these were the endpoints here, all-cause mortality, huge benefits. Look at the benefits on heart failure, 64%, all cardiovascular events down 34%. Fantastic benefits of using these agents in the very elderly. And we were all very worried about treating 80 plus patients, but I think this really exonerates the use of such agents carefully and gently, but nevertheless of using these agents in the very elderly. And I think the SPRINT trial has also given support to that belief that we should treat over 75s. Now turning to LVH, this were patients with hypertension and left ventricular hypertrophy, got randomized to atenolol plus a low-dose thiazide, or losartan, the ARB, plus a low-dose thiazide. So added into both these were low-dose thiazides, but essentially it was beta blocker versus ARB. And you saw here overall a significant reduction in the classic 3-point MACE. Important to point out that benefit was all about stroke. It was not about coronary disease. Actually, coronary disease protection was better with atenolol than losartan. Only about 9%, not significant, but it was in the direction of a sort of prior prejudice that the ARBs were not as good at coronary protection as ACEs, for example, but good for stroke protection. And this 13% reduction in the primary endpoint was driven by stroke benefits. Against atenolol, which isn't famous for being particularly good at anything in cardiovascular protection except in secondary prevention. What about heart failure? Well, once again, lots of guidelines about heart failure, RAS blockade, beta blockers, diuretics, aldosterone antagonists, all with good trial evidence to support their use. And there are standard heart failure guidelines to tell us what to do in that setting. But all four of these drugs have got good trial evidence. So now we come back to two drug combinations, and I want to show this really around the issue of ethnicity. Look here, two lots of American guidelines produced within a couple of months of each other. And the ASH-ish guidelines, this is the American Society and ISH, for black patients recommend these three combinations. A is ACE or ARB, C is a calcium channel blocker, D is a diuretic. Easy to remember. So three combinations for black. But look, at the same time JNCA gave those three combinations for black patients, they recommended those three combinations for white patients and differed in terms of their recommendations. That tells us two things. We do not know the best evidence of what the right combinations should be by ethnicity. And this really highlights that issue. That needs sorting out. So to summarize the management for subgroups, here we see dyslipidemia or not. In the ASCOT trial, statins were used whether you had dyslipidemia or not. Indeed, they were normal or better than that in terms of their lipid profiles and showed big benefits. So the lipid-lowering arm of ASCOT showed that our patients should be given statins along with their blood pressure therapy, almost sine qua non. Type 2 diabetes, we've got RAS blockade plus a calcium channel blocker. In ACCOMPLISH, it was benazepril was the RAS blocker. And we got ACE plus thiazide-like in ADVANCE, showing the benefits of lowering the blood pressure. And let me point out that in ADVANCE, that was irrespective of baseline blood pressure. Many of these were not hypertensive. So let's turn to established cardiovascular disease, those with established vascular disease or at high risk. For coronary disease, we know all this: ACE plus beta blocker plus statin plus dual platelet therapy, and there's loads of trials supporting that. Stroke, those with established stroke, less evidence really is in the PROGRESS trial. That's an ACE inhibitor plus thiazide-like. For the very elderly, we've been through this. Cysture gave the dihydropyridine calcium channel blocker. Shep gave chlorphalidone, thiazide-like, and Hyvec gave the ACE inhibitor perindopril plus indapamide, starting with indapamide, adding perindopril. That was the very elderly. Left ventricular hypertrophy, ARB plus thiazide, that's life. And in heart failure, we've got the 4 standard drugs used in multiple trials and demonstrate each one of these has got good evidence. Ethnicity, we don't know. That's not for Denmark, that's don't know. We don't know the best combinations of therapy by ethnicity, and we need to find that out. Most of the world's hypertensives don't have definitive evidence as the best first or second line agent. That's appalling, I think. So this is work in progress. There's a trial called Creole going off in sub-Saharan Africa, which is going to at least tell us which combination is the best in terms of blood pressure lowering. So finally, ladies and gentlemen, this is a classic picture of how not to treat blood pressure really. It's just the standard way. The doctor, that's the guy on the right, gets hold of an arm and he squeezes it. Depending on how high the mercury column goes, dishes out tablets, ignoring the object attached to the arm. If we really want to save this guy from having a myocardial infarction or indeed a stroke, we've got to cut down his cigarettes, deal with his alcohol and his obesity. So we need to break the wall down. We need to look at all their risk factors. But classically, it's important to say here there are 3 tablets. That's symbolic, if you like, of the fact that most of our patients need 2 drugs to lower their blood pressure, and they should probably all get a statin. And if you could give all those as a single tablet, then we may well do a lot better, because they'll take their tablets more carefully if there's only one of them versus 3. Okay, there are my thoughts about managing hypertension with comorbidities. I'm sorry if we've had to go through that quite quickly. Thank you very much indeed for joining me. I hope that was useful and interesting, and I look forward to any feedback you may have about my thoughts, and I hope you have a marvelous weekend. Thank you and goodbye.